So yes, welcome everyone. Today is our sixth series for this year. It's great to have everyone joining us today. It's always a pleasure. So today we have three speakers speaking on different topics, and we are very glad to have them with us. And we will start off today. I will introduce our discussants. We have two discussants, Prof. Soichi Oya and Prof. Itichai from Thailand, and Prof. Soichi Oya is from Japan. And today's webinar will be chaired by Prof. Naoki Otani. So without much delay, I shall pass it over to Prof. Otani. Prof. Otani, you want to take over? Or would you like me to introduce the speakers?
Yeah.
Okay, so we will start off. Our first speaker today is Prof. 𝒓𝒂𝒂𝒏𝒊𝒔𝒂𝒍. Prof. 𝒓𝒂𝒂𝒏𝒊𝒔𝒂𝒍 is a consultant neuroradiologist and neurointerventionalist in National Neuroscience Institute, NNI, Singapore. And today she will speak on parasagittal sinus and superior sagittal sinus dural arteriovenous fistula. So Prof. Wiki, are you ready?
Yes, I am.
Okay,
Hi, thank you so much
nice
for the introduction.
Please start.
Would you like me to share my slides now?
Yes, please do. Yes. Okay, we can see your slide.
Okay.
All right, great, good.
Okay, thank you. So I will start soon. Okay, hi everyone, I'm 𝒓𝒂𝒂𝒏. I'm from Singapore. I work predominantly in the National Neuroscience Institute of Singapore. I just recently came back from my fellowship in neurointervention in Toronto Western Hospital. I work with Professor Timo Krings, and we work on this project, a very interesting one, on parasagittal and suprasagittal sinus dural arteriovenous fistulas. So I thought it would be good for me to share this topic with all of you today, and happy to discuss. Just a little bit on the introduction. So dural arteriovenous fistulas, they are abnormal arteriovenous shunts located on or between the layers of the dural matter. It is a very common disease. Sorry.
I think.
Am I muted?
No, we can hear you.
Yes.
Is there something wrong, Prof. Oya? Prof. Otani, is there something wrong? Oh, I think it's just a interruption. Okay. Yeah, you can go.
Yes, I can hear you. I can hear you. Yeah.
Oh,
Okay.
you're not Professor Key, you are not starting sharing slides yet?
No, we can see it. We can see it.
Yep.
You can
We can see that. Yeah.
It's only my side.
I have shared my screen though. I have shared the slide.
It's working well. It's working.
I can't see it. I cannot see it.
You cannot see it.
Problem with the internet.
Is it only me or?
No, actually, it's
at other place it is seen. We are able to see the slide on slide mode also.
You are able to see it?
Yes,
Do you
we
want me
can.
to stop share and try to share again? Is it necessary?
Yeah.
If it's possible, please.
Yeah, of
because
course.
I can't see it at
No
all.
problem. Let me stop sharing, and then I will share again.
Now it's on it. Yeah, it's on.
Okay.
Thank you.
Great, no problem. Okay, so let me go back to the introduction. So dural arteriovenous fistulas, as I said, is an abnormal arteriovenous shunt. It is a very uncommon disease with an incidence of about 0.5 per 100,000 adults per year. So no one knows exactly why and how and when it happens, but it was observed that sinus thrombosis, infection, trauma, surgery, and radiotherapy may precede the formation of dural arteriovenous fistulas. The conditions that I just mentioned could then lead to venous hypertension and venous ischemia, which may then increase the expression of androgenic factors such as HIF1 and VEGF, leading to angiogenesis and dural arteriovenous formation. Now, this is an example of a patient with previous right parotidectomy and radiotherapy, which then had developed this dural arteriovenous fistulas about 11 years later and confirmed on angiogram to have a superior petrosal sinus DABF, which then treated for this. Now, the most common locations for dural arteriovenous formations that we commonly seen is on the transverse sigmoid sinuses and cavernous sinuses. And those involved the superior sagittal sinus was only seen in up to 5% of all the dural arteriovenous cases. We sometimes came across these umbrella terms of SSS-DAVFs, convexity DAVFs, or Fox DAVFs. These terms, we have seen it in clinical practice and in the literature, and this term did not necessarily differentiate SSS-DAVFs from parasagittal DAVFs. The reported symptoms of SSS-DAVFs include weakness, numbness, headache, seizures, visual disturbance, dementia, gait disturbance, and tinnitus. And based on this systematic literature review, looking at 20 publications with 31 published cases, the patients were predominantly male. They were mostly a middle-aged group, around 54 years old. And they had very high hemorrhagic rate of 42% at presentation. And in terms of imaging features, they are mostly located along the middle third of the superior sagittal sinus, and all cases had MMA supply. And so looking into the definitions of SSS-DAVFs versus parasagittal DAVFs, SSS-DAVFs are sinus-type fistulas with shunt points on the dura surrounding the sinus or the parasinus wall, whereas parasagittal DAVFs, they are non-sinus type fistulas that had shunt points on the dura mater in close proximity to the dural penetration of the bridging vein. So this diagram actually demonstrates it really well, in which the sinus fistula had fistulas point on the sinus wall, and the non-sinus fistulas had fistulas point on the bridging vein next to the dural penetration. So together with Professor Timo, we look at cases involving the superior sagittal sinus and parasagittal sinus with the aim of differentiating their clinical presentations, imaging characteristics, and hopefully to develop a treatment strategies for each of these entities. So we look at cases across 6 years, from January 2017 to December 2022. We identify all the DAVF cases. We had slightly over 150 DAVF cases, and we identify those involved SSS or parasagittal sinus. And we had 19 patients in total, 15 cases of a parasagittal DAVF and 5 cases of SSS DAVF. One patient had both parasagittal and SSS DAVFs. From here, you can kind of see we had more parasagittal cases as compared to the SSS cases, so about 3 times more common. Similar to previous literature review, our patients were also predominantly male, and they are also of around 5 to 6 decades at presentation. But surprisingly, our patient had very low hemorrhagic rate. Only 1 patient presented with intracranial hemorrhage at presentation. In sinus type dural arteriovenous fistula, going into the definition, this sinus may progressively compartmentalize as they are exposed to constant high fistulous flow and may eventually occlude, leading to cortical venous reflux and congestion. So this patient may start up as Borden type 1, may then progress to type 2, and eventually type 3 if left untreated. In a non-sinus type dural arteriovenous fistula, there's direct drainage to the cortical vein and therefore naturally a Borden type 3 to begin with. Now, this classification helps us to also kind of qualify the venous drainage, the severity, and therefore the severity of the disease. In our cases, SSS-DAVFs, all the SSS-DAVF cases were in the Borden type 2 classification, whereas all the parasagittal DAVF cases were in Borden type 3 as expected. So we couldn't really explain the low hemorrhagic rate in our cases. The best explanation would be, in my opinion, would be early presentation. The patients presented early, as nowadays we had higher rates of imaging for non-specific symptoms, and therefore we kind of treated the patient early and prevented hemorrhagic rate for these patients. So in terms of any associated preceding events, all the cases in the SSS group had previous trauma, either previous trauma or thrombosis, whereas all but one cases in the parasagittal group had no known preceding events. So no previous surgery, no previous radiotherapy, no previous infection, no previous trauma. The only thing that I think we still can't exclude is previous bridging vein thrombosis, as bridging vein thrombosis can be clinically silent due to the abundance of collateral circulation, whereas SSS thrombosis often cause backflow obstruction of all the draining veins before the lesion location and is more commonly clinically symptomatic. Now let's go into the next section, focusing on imaging characteristics of these fistulas. So we noticed that for both the parasagittal group as well as the SSS group, the most common shunt locations were located on the middle third of the suprasagittal sinus. Now, this is very similar to the previous literature review. So why is the middle third of SSS the most commonly involved segment? So we were kind of curious about it, so we read a little bit deeper. Now, bridging veins are larger in caliber along the middle third of the SSS. They are larger in caliber along the posterior frontal and parietal regions. Observation number 2, the bridging veins join the middle segment of the SSS predominantly in either a perpendicular fashion or retrograde fashion, or they form this hairpin loop before they join the suprasagittal sinus, or maybe they'll form a lacuna before they join the suprasagittal sinus, as compared to the anterior segment, in which they usually join in an antegrade fashion. So hemodynamic study actually shows that if the veins is larger, the bridging veins is larger, or if the entry angles that it joins the suprasagittal sinus is less than 65 degrees, meaning a retrograde fashion, then it may precipitate to the formation of cerebrovenous thrombosis. This is a very nice picture showing what I just described to you, in which the bridging vein in the anterior segment and the posterior segment tend to be smaller as compared to the middle third of the SSS. And in the anterior segment, it usually joins the SSS in an antegrade fashion, whereas in the posterior segment, it could join as a retrograde fashion, but it's usually smaller in caliber, whereas in the middle third segment, it's more predisposed to thrombus formation because number 1 is larger in caliber, and number 2, it may and is most commonly joined as a retrograde fashion. So next on imaging characteristics, looking at the fistulous point. Parasagittal group, the fistulous points are usually on the junctional zone of the bridging vein and the SSS, and on the suprasagittal sinus, the suprasagittal sinus DVF, the fistulous points are on the sinus or parasinus wall as described earlier. So this is where the fistulous point is for parasagittal duroarteriovenous fistulas, with the fistulous point on the junctional zone as it joins the suprasagittal sinus. And for suprasagittal sinus DAVFs, the fistulous points are on the sinus wall. Now, to explain the occurrence of fistulas, why is it mostly at the junctional zone of the bridging vein and the SSS? Could be due to a couple of factors. Factor number 1 could be a change in caliber. The veins are usually of uniform caliber along its subarachnoid course, but as it enters the dura, it may become puffy looking just prior to its focal segment of constriction at the junctional zone prior to it joining the suprasagittal sinus. So number 1 is change in caliber. Number 2, it could be because of change in histology. So the histology of bridging veins, as any other vessels, tunica adventitia, media, intima. The adventitia consists of collagen fibers and elastin to prevent overexpansion of vein. Media consists of elastin and could consist of smooth muscle cells, although this was not consistently proven in studies. So there was this debate of whether it was active or passive drainage. Depends on the presence of smooth muscle cells in the tunica media. And the inner layer often consists of endothelium covered by elastin tissue. So based on histology, it's often longitudinally oriented and pretty densely packed along its subarachnoid course, but as it enters the subdural course, it can become circumferentially oriented and is often looser webbing, and so potentially weaker there. And all this change in histology, change in caliber may lead to flow disturbance, thrombus formation, and eventually DAVF development. And also, when there is angiogenesis, when there's DAVF formation, there's arterialization and there's higher flow. And this may lead to accentration of the constriction at the junctional zone, which then leads to this finding in our study. In the parasagittal group, most of the cases had either an occluded junctional zone, occluded connection of the bridging vein to the suprasagittal sinus, or a stenosed junctional zone of the bridging vein to the suprasagittal sinus. So we think this is related to the sphincter mechanism at the junctional zone, related to venous dilatation as a result of arterialization, which then led to stenosis and occlusion of the connection of between the bridging vein and the suprasagittal sinus. Another interesting findings on imaging characteristics is cortical venous reflux. In the parasagittal group, we observed that the cortical venous reflux only occurs ipsilateral to the fistulous point, and in the suprasagittal sinus group, it could occur bilaterally. So this is suprasagittal sinus dural arteriovenous fistulus, in which the blue arrows pointed to cortical venous reflux on both sides, the right and left side. Whereas parasagittal DAVFs, despite bilateral arterial fetus, the cortical venous reflux was only seen ipsilateral to the site of fistula. And why is that so? Because the cortical veins, the bridging veins, is often limited by dura propria and the midline that are adhered back to back, and therefore there's no chance for bridging vein on one side to communicate with bridging vein on the other side. Whereas in the SSS group, as I mentioned earlier, in a higher grade DAVFs, they may have bilateral cortical venous reflux. So now let's go into arterial fetus. Similar to previous literature review, we see MMA supply in all the cases, of all the parasagittal cases, as well as the SSS DVF cases. And in a lesser frequency, we also see STA and OA supply, and in an even lesser frequency, we see pure dural supply. But from these numbers, this percentage that I highlighted here, you could kind of get a sense that maybe SSS DAVFs are more vascular as compared to parasagittal DAVFs. So in all the cases of parasagittal and SSS DAVFs, we treated them endovascularly, and all but one cases were treated via a transarterial modality. And MMA arterial fetus were the primary route for transarterial embolization. With this treatment approach via the MMA, complete angiographic occlusion was achieved in 14 out of 15 of parasagittal DAVFs. Now, the only one case that we treated transvenous via transvenous route was this patient with variant SSS findings, in which we see bifid bifid channels, split channels of SSS. So one channel was disease and the other channel was patent. So we had our balloon sinus protection along the patent segment, and then we did a transarterial embolization via the disease segment. So then we may ask ourselves, is balloon sinus protection really necessary in terms of endovascular treatment of either SSS or parasagittal DAVFs? Now, in a parasagittal group, most of the cases we did not use balloon sinus protection, whereas in the SSS group, we use it kind of in a split manner, and I will go into a little bit more details. Now, based on what we understand earlier, that oftentimes the junctional zone is either stenosed or occluded, balloon sinus protection may not be necessary because there's a very low chance of reflux of liquid embolic materials into the suprasagittal sinus. Therefore, we propose that in parasagittal arteriovenous fistulae, especially in cases of occluded or narrow connection with the suprasagittal sinus, balloon sinus protection of the suprasagittal sinus during embolization may not be required. Whereas for SSS-DAVFs, as the fistulus is on the sinus wall with direct drainage to the suprasagittal sinus, we believe that balloon sinus protection is an important strategy in treatment of suprasagittal sinus DAVF with patent sinus. And why were some of the cases of SSS-DAVFs was not done under balloon sinus protection is because 2 out of 5 cases had occluded or stenosed sinus, and the other case had difficult venous access. There was an occluded right transverse sinus and hypoplastic left transverse sinus. So the patient with challenging venous access with patent SSS and without balloon sinus protection actually had reflux of onyx into the SSS, although it was non-occlusive in this case and the patient was asymptomatic. Now, looking at the number of treatment sessions required to achieve complete fistulous occlusion, for parasagittal DAVFs, we managed to achieve complete occlusion within 1 session, whereas in SSS group, it requires more sessions with an average of 2.4 sessions. Again, in the SSS group, 1 case did not manage to achieve complete occlusion in the end, but in the parasagittal group, we managed to achieve complete occlusion in all cases. Also, in the SSS group, we had a couple of complications, and these were complications of scalp necrosis post-embolization, and this was likely attributed to penetration of liquid embolic materials to the scalp arterial fetus. Despite some of the cases with complications and with incomplete occlusion, we managed to achieve symptomatic relief in all cases of parasagittal and SSS DAVFs. But looking at the numbers, the rate of recurrence, the rate of retreatment for recurrence, and the rate of incomplete angiographic occlusion was slightly more in the SSS group as compared to the parasagittal group. So I've come to the conclusion of the presentation. We think it's important to differentiate parasagittal DAVF from SSS DAVF. The parasagittal group had shunting zones on the junctional zone of the bridging veins and the SSS with ipsilateral cortical venous reflux, while the SSS DAVFs had shunting zones on the sinus or parasinus wall with bilateral cortical venous reflux. So these are kind of important imaging findings for us to differentiate the two, the parasagittal versus the SSS group. Now, in terms of treatment strategies, we could really consider transarterial embolization using liquid embolic materials in all cases, especially if they have good MMA supply. And MMA can always be used as the primary treatment strategies in most cases if the course is not too tortuous for access. And in terms of balloon sinus protection, we think that in parasagittal DAVFs with occluded or stenosed connection of the involved bridging vein with the SSS, the use of balloon sinus protection during embolization is not necessary, but in suprasagittal sinus DAVFs with patent sinus, balloon protection is slightly necessary. And also in these cases, they may require more sessions or more complex treatment strategies to achieve complete cure. That's it from me, and thank you very much for your attention. Before I end, I would like to acknowledge the guidance from Professor Timo Krings, as well as the team in Toronto Western Hospital, Professor Antti Lindgren and Professor Hiro Kiyosu for their contributions in this paper, and also Dr. Weekly Lee, my teacher, and the rest of the NNI team. Thank you very much.
Thank you very much, Professor Kee. I will give the floor to Prof. Oya or Prof. Otani. Maybe Prof. Otani, you want to start first, and then Prof. Oya and Prof. Itichai, I think he's here also.
Okay, Dr. Oya, so do you have any
Yes.
question and comment?
Yes. Thank you, Dr. Kee. If you have any question or comments, you can start first.
Okay. Okay. So thank you. So Dr. Fei, and so for your good presentation. So based on your based on your so much experience and so your papers in details. So my question is so how do you think about the differences of the hemorrhagic risks? So between the parasagittal dural AVF and the SSS dural AVF. So which is so higher hemorrhagic risk? So one more, please. Let me know.
Yes, so you see, based on Borden classifications, SSS usually start up as either a Borden type 1 or Borden type 2, type 2, and then progress to Borden type 3, whereas parasagittal is naturally a Borden type 3 classification. So in terms of aggressiveness, perhaps the parasagittal group would be more aggressive than the SSS group. And also in our patient cohort, the only one case that had hemorrhagic presentation was in a parasagittal group. So perhaps the parasagittal group is slightly more aggressive as compared to the SSS counterpart.
I see. And so just in case the scalp necrosis, so in that case, transarterial embolization was performed, right?
Yes.
No?
Yes.
Transarterial embolization.
Transarterial, that's right. That's also one of the message I would like to deliver through my lectures is I think SSS DAVFs are more difficult to treat as compared to parasagittal DAVFs.
I see.
It could be due to a number of factors. It could be because they are more vascular and they just require more complex treatment strategies. And you see the two cases with scalp necrosis, I suspect it's also because of kind of overzealous embolization in order to achieve cure and therefore resulting in scalp necrosis. But I know in Japan that there's one center that they use what we call a tight band application on the scalp. To kind of prevent these complications of scalp necrosis. We have not had this experience in our center, so it would be really nice if you know anything about this tight band application.
And so last question is, so what type of the embolic material, so fluid material, so what type of the material do you use, so, such as onyx or sometimes the coil embolization.
Yes, so we usually use onyx. Of course, we use squid as well sometimes, but we usually use onyx. It really depends also on the technique used, because if it's a dual microcatheter pressure cooking techniques, then we may also use glue and coil to kind of form the cast to prevent backflow of the liquid embolic materials we use. But oftentimes we also use balloon microcatheter to achieve the pressure cooker effect.
Yeah, thank you so much. So you are a good skillful technique. Thank you so much.
Thank you.
I understand. Please, Dr. Oya.
Okay, all right. Thank you, Dr. Key. I enjoy your talk very much. And it was especially interesting to me that the middle third of the bridging veins are more exposed more frequently to the risk of the development of the dural AVF because of the angle of the conference. And also I didn't know much about the histology of the bridging vein that may increase the risk of occlusion. That was very interesting. And my first question is that you showed the data that the trauma is more frequently involved in the mechanism of the SSS dural AVF compared to parasagittal dural AVF. What's the rationale behind it?
So I think it's overall very low disease incidence, and therefore it just happened that in our group, that 5 patients with SSS DVFs, 3 of them had previous trauma, whereas in the parasagittal group, none had previous trauma, but it's because of the skull fractures that actually impinge on the superior sagittal sinus, causing narrowing. And this narrowing actually caused hypoxia and therefore angiogenesis and DVF formation. Whereas in the bridging vein, in the parasagittal group, somehow most of the cases had no known preceding event. And so the only thing we haven't really excluded is bridging vein thrombosis, which then may be clinically silent. So that was our postulation that probably there was a clinically silent bridging vein thrombosis, which then leads to thrombus formation, hypoxia, and subsequently arteriovenous formation.
Okay. And the second question is, if I understand correctly, you mentioned that SSS dural AVF is more likely to develop to higher Boden type, right? Like from Boden 1, 2, 3.
Yeah. So they may start up as a lower grade Boden classification,
right.
progress later. Yeah.
Okay. So there, so for example, when we see the simple transverse sinus dural AVF and the patient had very minor symptoms, we may observe the dural AVF. But do you think the early intervention to the SSS dural AVF is helpful to achieve the better prognosis compared to, I mean, the transverse sinus dural AVF, I mean?
Yeah. So this is also a little bit kind of struggle that I have because we know it's not easy to treat SSS DVF from the data that we had in our center. And while they are still at the Boden type 2 kind of classification, not yet going to the isolated sinus Boden type 3 kind of group, is it worth treating them, knowing that they may have, number one, incomplete cure, or they may have complications? So this is, I haven't have a very, very good answer to this question. But I personally think we should then decide based on a case-by-case basis, depending on how difficult we think is the treatment strategies and how high the complication risk may be before we then decide whether to treat. And I can't really compare it with the transverse sinus DVFs. I think, again, it's on a case-by-case basis, my personal opinion.
Okay, thank you. Thank you. I see Dr. Suresh raising hand.
Yes. Nice presentation, Dr. Key.
Thank you.
There are 2 queries I just wanted to know. SSS DVF, as there is a corticovenous reflux bilaterally, do you think that they bleed bilaterally or they bleed on the dominant side of the corticovenous reflex? First answer that, then I'll ask you the other question, please.
Yes. So I think it depends on the venous collaterals. Although they kind of have bilateral corticovenous reflux, but they don't bleed unless there is too much venous congestions, not enough venous collaterals to supply that part of the cerebral hemispheres. So I think it depends on the venous collaterals.
The other question is that, as you told that middle third is much more common. Is it the central vein which is the culprit?
You see, there are a variation of there's this variation of the SSS and the bridging veins formations. So we could only go back to data on anatomy, and so we think it's related to the caliber of the bridging vein as well as the course that it enters. It may cause more flow turbulence, higher risk of thrombosis, and therefore leading to DAVF formation.
As you told that there are 46% chances of bleed. So this 46% hold true at the other location also, like transverse sinus. So if we detect an incidental fistula, then is it mandatory to treat, or it should be, if it is Boden type 3, then only we should treat an incidental one?
No, so the 42% was actually based on a systematic literature review that was published earlier in 2022. I think it could also be selection bias because we tend to publish papers that we think that they are more severe with higher impact. We may not publish those papers that we may not publish those cases that patient did not present with a bleed. So number one, it could be publication selection bias, and therefore the high hemorrhagic rate, because we didn't observe this in our patient cohort. And so it could either be earlier presentations in our patient cohort, or it could be also attributed to selection bias in terms of publication. So do we wait until patient is borderline type 3 to treat? I don't think so. I think we should, obviously, if it's borderline type 1, we know that and patient is asymptomatic, we know that there's a chance for resolution or kind of stabilizations of the DVFs. And if the risk of treatment outweighs the risk of natural disease, then we obviously shouldn't treat. But if it's borderline type 2, I think, and the patient is symptomatic, or borderline type 1, and if patient is symptomatic, we should definitely consider treatment. If we think the treatment the treatment risk is not high and it doesn't outweigh the risk of natural disease, then I think we should definitely consider treatment.
Prof. Suresh, you're muted. You're saying something, you're muted.
1 minute. This is for everyone, one comment that when there is a patient of traumatic brain injury and we find a bleed at a location which is quite unusual in that patient, I think we should subject these patients to the CT angiography with the venography, so we detect these patients on time and we get them treated accordingly. Dr. Key, do you agree with me on that? Or
Yeah, definitely we should do early imaging to pick up either underlying thrombosis or underlying fistulas that may then attribute to the hemorrhage. We should definitely go deeper into the underlying etiology of this hemorrhage.
is CT angiography and venography, will it pick up 100% all the cases? Or many a times you don't pick them up in CT angio and veno and you have to do the DSA? What do you think?
I think most of the time we'll be able to pick up underlying SSS thrombosis as well as DAVFs, but the only thing that we may not pick up is bridging vein thrombosis.
Okay, thank you. Thank you. So nice. Okay.
I think we have a question from Prof. Ithijai. Prof. Ithijai, you want to ask your question before we can go on to the next speaker?
Yes. Can I have only one question? Short question.
Yeah, definitely.
Yes, thank you so much. For Dr. Kier, thank you so much for your presentation. I have one question for some limitation of the treatment by transvenous approach, because in some cases of the superior cytokine dural AV fistula is one of the most difficult to treatment of AVF in neuro intervention field. If we cannot access by conventional transvenous approach, like they have like the jugular vein thrombosis and we cannot recanalization. Do you have another question to approach, like the experience of the hybrid surgery? That means direct puncture of the superior cytokine and use some embryonic material to occlude above the AVF. Do you have like about this experience?
Oh, we don't have experience for SSS or parasagittal DAVFs for hybrid surgery. In fact, all our cases were treated solely endovascular. But I think for certain cases, if we really can't access it endovascularly, and then we can definitely discuss with our neurosurgeons. And then from there, we can take it from there, what to do next. But in our local setup, we didn't have that experience.
Thank you. Thank you.
Okay, I think we can move ahead. Sharon?
Hello, everyone.
Okay, Professor Kato, do you have anything to say?
It's fine. Thank you very much, Kate. Thanks, excellent talk. So Timo is a good teacher, I think. Yeah, I met him many times. What about the radio surgery for treatment, one option? How do you think about radio surgery?
Radio surgery for dural artery venous
Gamma ray.
fistulae.
Yes. Yes.
Yeah, actually, we have also discussed with our radiosurgery specialists before for all these dural artery venous fistulae. But the curative rate is actually not high. Apparently, it's less than 50%, especially if it's very vascular. And so they do not recommend it, especially not as first-line treatment.
Okay, thanks. So the main symptom is a tinnitus, you said?
No, so actually I didn't share the slides, but it's a variety of clinical presentations, from tinnitus, from headache, from weakness, numbness, to in fact dementia or headache. Yeah, so it's a variety of symptoms.
Okay, thanks. So it's very interesting conversation. Thank you.
Thank you.
Thank you, Dr. Key. That was a very nice presentation on dural AV fistulas. And some of these that we have seen are very difficult to treat because they have multiple feeders. Sometimes they recruit from both the sides, you know, the middle meningeal artery, the occipital artery, all of them are recruited. And then, you know, sometimes we do stage embolization for this and sometimes can be very difficult to treat. So thank you for your presentation. I'd like to invite the next speaker, Dr. Divya Palanisamy, and she's a consultant neurosurgeon at Vellore, India, and she's going to be talking about a medulloblastoma. Divya?
Yes, ma'am. I'm sharing my screen.
Yes, go ahead.
Can you see, ma'am?
No, not yet.
Can you see my screen, ma'am?
Yes, put it in full screen.
Yeah. Okay. So, I'm Dr. Divya Palanisamy from Tamil Nadu, Vellore. I'm going to present a rare case of middle cerebellar peduncle, cerebellopontine angle medulloblastoma, which was removed through retrosigmoid transpetersal fissure middle cerebellar peduncle approach. Medulloblastoma constitutes only 1% of tumors in adults, but 9.2% of brain tumors in children. And among the pediatric post-fossa tumors, medulloblastoma forms around 25 to 40%. So common location of medulloblastoma are fourth ventricle and vermis in children, cerebellar hemispheres in adult, especially lateral cerebellar hemispheres. So other than these common locations, medulloblastomas are reported in cerebellopontine angle, but only less than 50 cases are reported in the literature so far. Most of them are intraaxial tumors arising from the external germinal layer of the pons and the cerebellum, and pure extraaxial cerebellopontine angle medullomas are reported in very few cases. So treatment of medulloblastoma consists of aggressive surgical resection followed by chemotherapy and radiation therapy. Why aggressive surgical resection? Because the post-operative risk stratification depends on the residual volume of the tumor. Average risk patients are those who have less than 1.5 centimeter square of residual tumor, and the CSF cytology is negative for any tumor spread. High risk patients are those who have more than 1.5 centimeter square of residual tumor, and they have MRI or CSF evidence of spinal neuraxial spread. Generally, age more than 3 years, no metastasis, average post-operative risk, and laterally placed tumors carry a better prognosis. With this background about medulloblastoma, I move on to the child which I operated. That was a 5-year-old male child who presented with 3 weeks history of frequent episodes of vomiting and progressive difficulty in walking and also speaking. At the time of consultation in my OPD, the child was conscious, but he was obeying to simple commands on persuasion. He had right gaze paralysis and nystagmus. Actually, he was brought by his mother like a newborn child. He was unable to hold the neck. He was unable to lift the limbs, and he was on nasogastric tube feeding. This was the MRI scan, which was taken outside from his native place. And this is a T1 weighted image, which shows a hypointense lesion in the arising from the right side of the pons extending into the middle cerebellar peduncle. And this is the normal pons, normal pontine tissue we can see, and the tumor was causing mass effect on the fourth ventricle, but there was no hydrocephalus. And there is a good rim of tissue in the floor of the fourth ventricle. This is a T2 weighted image which shows a heterointense lesion, and there is edema we can see in the pontine tissue. So on contrast injection, actually the tumor was heterogeneously well, enhancing with contrast. Diffusion weighted image I didn't put here, but actually there was no diffusion restriction in the tumor. So the first differential diagnosis for this imaging was pontine glioma by the radiologist. Second possibility we thought of medulloblastoma. So the surgical approach, we went ahead with the surgery. So the surgical approaches for tumors involving the pons, or there are multiple approaches, anterior, lateral, and posterior. Retrosigmoid approach is the commonly used approach because, however, this approach actually gives limited access to this region, the pontine region and the middle cerebellar peduncle region. So sometimes in some cases, we may have to resect part of the cerebellum or retract the cerebellum to reach the area. So extended retrosigmoid approach by drilling the mastoid, skeletonizing the sigmoid sinus. Yes, this approach improves the access to this region and reduces the need for the cerebellar retraction or the resection. However, it needs extensive drilling of the bone, and there is long duration of surgery, chance of CSF leak, injury to the sigmoid sinus, thrombosis of sigmoid sinus, all those are there. So coming to the retrosigmoid transpetersal fissure approach, coming to the anatomical considerations. So to reach pontine lesions, there are safe entry zones. There are 3 for the pons, that is supratrigeminal zone, which is located above the 5th cranial nerve, and peritrigeminal zone, which is located in front of the 5th cranial nerve behind the pyramidal tract. And this is the lateral pontine zone, which is located between the 5th and the 7th cranial nerve at the junction of pons with the middle cerebellar peduncle. Even middle cerebellar peduncle is a safe entry zone to reach pontine lesions. So all these safe zones can be approached through the transpetersal fissure approach. This is the anatomy of the cerebellopontine angle. This is 5th cranial nerve, 7th cranial nerve, and the flocculus, and this is the middle cerebellar peduncle, and this is the apex of the cerebellopontine angle. The petersal fissure or the horizontal fissure starts at the apex of the cerebellopontine angle and then goes laterally between the superior and the inferior semilunar lobes. So opening this horizontal fissure or the petersal fissure actually gives very good access even up to the posterolateral aspect of the middle cerebellar peduncle. So this approach was first reported by Fujimaki and Kirino et al. For microvascular decompression of the trigeminal in trigeminal neuralgia cases. In 2010, Ohio et al. Did anatomical study of this fissure split approach, and he used the same approach to remove brainstem lesions in his patients, and he was able to achieve gross total excision in 9 out of 10 patients. And in 2016, Spetz's team reported on transpetersal retrosigmoid craniotomy, transpetersal fissure, middle cerebellar peduncle approach to remove the lesions in the pons. So there are multiple articles reported after 2016 on this approach. Lawton et al. Did a comparative study of extended retrosigmoid approach and the retrosigmoid approach, transpetersal fissure approach. He did an anatomical study and he found that the accessibility and maneuverability was better in extended approach than the routine retrosigmoid transhorizontal fissure approach. Snyder et al. Actually compared the retrosigmoid transpetersal fissure approach with the transpetersal pre-sigmoid translabyrinthine approach, but he found that the retrosigmoid transpetersal approach was superior. Though the access is same in both the approaches, the time duration for the surgery was less with the retrosigmoid transpetersal fissure approach. So means for most of the neurosurgeons, retrosigmoid approach is a familiar approach. Adding the fissure, horizontal fissure opening increases the access to this middle cerebellar peduncle and the lateral pontine region. So it avoids the disadvantages of extended retrosigmoid approaches like the extensive drilling, the need for long learning curve, all those things. So coming to the surgical video of the child which I operated, the child was put in the left lateral position and then with the right side up, and standard retrosigmoid suboccipital craniotomy was done, exposing the transverse and the sigmoid junction. So the duro was opened. And here the CSF was released from the cistern. Cerebellum did not relax much, so I had to do lateral to medial horizontal fissure split approach. So here, this is the horizontal fissure. Sharp dissection of the fissure is required. So I'm starting from the lateral aspect. I was slowly moving to the medial aspect of the fissure, slowly. So here I entered the CP angle, and this is the pons, and the arachnoid is divided, and here is we can see the lower cranial nerves. Again, back to the horizontal fissure splitting. So from lateral, I went medially, and superficial to deep, I went slowly. It took some time to resect the fissure, especially in a child. It was somewhat difficult. So sharp dissection of the arachnoid was performed. Now we can see the pons. This is the superior semilunar lobe, inferior semilunar lobe, horizontal fissure, and this is the pons. Arachnoid was opened. Again, back to the deeper portion of the horizontal fissure. Slowly it was dissected. Now here, inferior semilunar lobe, this is the pons. We can see the seventh nerve here, it's plagued by the tumor. Pons was full of tumor. So seventh nerve is completely opposed to the pons, and these are the lower cranial nerves we can see. Again, back to the horizontal fissure. So superficial to deep dissection. On that, I started exposing the middle cerebellar peduncle. Here we can see the middle cerebellar peduncle. So pons, middle cerebellar peduncle, superior semilunar lobe, inferior semilunar lobe. Fifth nerve I could not actually expose well in this case, but seventh nerve we saw. So fifth nerve to seventh nerve is the lateral pontine zone at the junction of pons with the middle cerebellar peduncle. And middle cerebellar peduncle is also a safe entry zone. So I try to reach the lesion through the middle cerebellar peduncle. This is the pons. So I used very low current, 5 milliampere bipolar current I used. And then slowly I went through the middle cerebellar peduncle towards the pons. I started seeing a grayish pink lesion. This is a very small opening in the middle cerebellar peduncle. I could see the lesion there. So I used the suction to suck out the tumor. The tumor was mostly friable, mostly suckable with the suction. I used the tumor holding forceps to take some bits for biopsy. Most of the tumor came out with the suction. I used the dissector to push the tumor into the tumor cavity. I used the suction to remove the tumor as much as possible, and also use the tumor holding forceps. These steps were repeated continuously. So push the tumor into the tumor cavity with the dissector, use the suction to remove as much tumor as possible, and also use the tumor holding forceps to remove the tumor. So inferiorly, I extended the middle cerebellar peduncle opening and pushed the tumor into the cavity. So these steps were repeated very often. So here, brainstem monitoring will be of great use. The tumor was highly vascular. When there was bleeding, I didn't use the bipolar much. I packed that area with Surgicel and waited for some time, and it stopped. And then I moved on to the next area to remove the tumor. So it was so deep inside. Now, inferiorly, I exposed more of the inferior cerebellar peduncle. And then I opened it more so that I can expose more amount of tumor. So again, with the dissector, tumor was pushed into, and then using the suction, it was removed with the suction. So bipolar was very rarely used. Very low current, it should be used. Brainstem monitoring will be of great use in these cases. However, we don't have in-house monitoring facility, so we have to arrange from other place. Due to money issues and unavailability, I couldn't use it. So now laterally, I am extending the middle cerebellar peduncle opening. I'm widening it laterally, posterolaterally, so that I can remove some more tumor. So now the same steps were repeated. So tumor was sucked with the suction. Most of it came with the suction. In one area, if it is bleeding, keep the Surgicel and pack it and move on to the other area. That's what I did. So the tumor was coming out very well. Once most of the tumor is removed, the bleeding also comes down. Some deep inside the pons. So we can see now with the dissector, the tumor was pushed posteriorly. We can see good chunk of tumor coming into the tumor cavity. All were sucked with the suction catheter. Now I'm retracting the pons with the retractor, and now after taking out all the surgical, I'm seeing tumor falling into the tumor cavity. All these tumor portions were removed gradually. It took 4 hours for me to remove the tumor slowly. So now most of the tumor has been removed. We start seeing the normal tissue posteriorly, posteromedially, all those areas. So most of the tumor was taken out and bleeding came down very well. After tumor resection, this is the cavity. I laid this cavity with 1 layer of Surgicel and then applied Surgiflow, and hemostasis was achieved. So this is the appearance. So there's a superior semilunar lobe, inferior semilunar lobe. This is the pons. Now at the end of tumor resection, we can start seeing the 5th cranial nerve there, 7th cranial nerve, and the lower cranial nerves. So this is the post-operative scan on the first day. I generally do one scan. It was looking good. And then the child was, Jesus improved to 10/15 on the first post-operative day. He was moving all 4 limbs. So he was extubated on the first day itself and shifted to ward. He was started on oral feeds, which he tolerated very well. On 4th post-operative day, he was able to hold the neck and sit without support. And on the 10th day, when he came for review, he was able to walk without support. And his gaze was normal, and there was very minimal or no nystagmus observed. And the histopathology was reported as medulloblastoma, desmoplastic nodular variant with BRICS mitotic activity and MIV labeling index of 70 to 80%. He was referred for chemotherapy and radiation therapy. So I thank my team from Narayani Hospital for all their support, and I thank Professor Suresh Babu and Dr. Sunil, my colleague from Chennai, for all their guidance. These are the references.
Thank you, Divya, for that nice presentation. And many people like to call this fissure the Sylvian fissure of the posterior fossa, to split it and reach the middle cerebellar peduncle. The fissure that is split.
Yes, ma'am.
It's many people like to call it the Sylvian fissure of the posterior fossa.
Okay. Okay.
So I'll hand over the discussion to Professor Kutani. You can take over.
Yes, thank you, Dr. Devia. So you are good surgical intervention for the medulloblastoma of the 𝑐𝒓. So I agree with your opinion. So that's so opening of the horizontal fissure. So before the tumor removal. So but how do you confirm? How do you confirm the horizontal fissure at first? So during the operation. So so in your presentation, so this is horizontal fissure you so showed in your video. So would you please surgical technique to confirm the horizontal fissure?
So identification of horizontal fissure, shall I go ahead, sir? So horizontal fissure, actually, we can easily identify during the study. It is possible.
So
that was the first case for me. I was able to
I usually so lateral side of the petrous surface of the cerebral. So I usually here is so horizontal fissure, and so to open the arachnoid and to CSF release. So after that, I usually so to cut and so arachnoid and so to open the horizontal fissure usually. So
here after releasing the CSF, the cerebellum was not falling back. So I had to open from lateral to medial. I couldn't, the cerebellum was not relaxing well. So that's why I went lateral to medial, but I was able to easily identify.
So another question is about the so origin of the medulloblastoma of the CP angle. So I usually know the superior filum of the fourth ventricle. So how do you think about the origin of these tumors? So do you think about it?
Superior medullary velum, that is a common occurrence of medulloblastoma, but the cerebellopontine angle, I went through the literature when I searched medulloblastoma in the pons. So in the literature, there is only one case that has been reported to arise from the pons, medulloblastoma in pons, not in any other paper, but they have written it as cerebellopontine angle. So they have done some research in the literature. They have said it could be arising from the external germinal layer of the pons or the cerebellum. So that's what I could see in the literature.
Okay. And the last question is about intraoperative monitoring. Intraoperative monitoring. So do you use the brainstem monitoring or
So it's India. I am in a private practice. Actually, we don't have in-house monitoring facility, but I call someone from Chennai, the neurophysiologist from Chennai. Actually, he comes and helps. But the child came in a very bad state. Then next day itself, I had to operate. Actually, I would prefer to operate with the monitor. But yes, we have to consider our limitations in India, and especially in away from the main cities. We are practicing away from a main city. So it is not that easy to get the monitoring urgently, in emergency conditions. Otherwise, I prefer to use. Generally I use.
Okay.
I couldn't wait for this case.
Yeah. Thank you for your good presentation. Thank you.
Thank you. Thank you. Thank you, Tanis.
I think Ben has a question. You want to go ahead, Ben?
Yes, thank you, Professor, for sharing your these interesting cases. I would like to ask about the bony drilling in your case, because you mentioned it's a transversal retrosigmoid. So what additional bone you need to remove in addition to a traditional retrosigmoid craniotomy? Is it equivalent to a posterior petrosectomy that you gain an extra corridor to approach the horizontal fissure that you want to open? What advantage that it will give you compared to a traditional retrosigmoid craniotomy? Thank you so much.
So I didn't remove any extra bone. It is a standard retrosigmoid craniotomy we generally use. So actually, after releasing the CSF, actually the cerebellum falls, Professor Otani told, and then you can immediately to laterally you can open the horizontal fissure. So there is no need for you to remove any extra bones. So it is a standard retrosigmoid approach. But in standard retrosigmoid approach, to reach the middle cerebellar peduncle without opening the fissure, it's not possible. So if you open the fissure, actually it gives more access for the middle cerebellar peduncle and also lateral pontine zone. So lateral pontine lesions can be approached through the standard retrosigmoid approach by opening the horizontal fissure. It's just extra opening of the fissure in the retrosigmoid routine approach. Nothing big.
I see. Thank you. I understand. Thank you.
We have, I think, another person with the hands up, but I cannot read Chinese character. I'm so sorry.
Professor Yoko Kado, I think.
No.
Okay. Thank you. It's May Opara. Yes, I'm currently
Okay.
a fellow.
Yeah, sorry. Yeah, I couldn't read. Yeah. Okay.
It's fine. It's fine.
Go ahead.
Thank you. I'm currently a fellow with Professor Yoko Kato. That's why you see the characters that way. All right. Thank you so much for the lecture this evening. I enjoyed it. I wanted to ask about the usual retrosigmoid approach, but the last speaker has already asked about that. So I just want to ask, you used a microscope for this. Would it have been possible to also do an endoscopic approach for this child?
Yeah, we can use but I have never used. I don't have an endoscope. I never used endoscope. I used only microscope for my cases. So I don't have much experience on endoscopic assisted microscopic approach, but definitely if endoscope is available, that should be definitely helpful.
Okay. So why I'm asking that is if we use the endoscopic approach, would it have been, if we had that opportunity, would it have obviated the need to go through this corridor which you went through?
I don't think so. Even through endoscope, I think you should open the fissure. You have to expose the middle cerebellar peduncle. So the middle cerebellar peduncle is covered by the superior and then the inferior semilunar lobes. So you have to open so that you can access the middle cerebellar peduncle. So middle cerebellar peduncle is a safe entry zone to reach pontine lesions, lateral pontine lesions. So to expose the middle cerebellar peduncle, I think you have to open the fissure. So endoscope may facilitate, but it will not obviate the need for the opening of the fissure. Whether it is microscopic or endoscopic, you need to open the horizontal fissure. That's what I feel.
Okay. Thank you so much. I appreciate it.
Thank you.
Okay. Well, thank you for sharing your experience. It was beautiful presentation. I personally love this approach and the frequent reuse, and because this is a very versatile approach. And we also reported the effectiveness of this approach in resecting the vestibular schwannomas, and we can minimize the retraction injury using this approach. And then let me just make a short comment. If for people who seldom use this approach, I think the coronal MRI, coronal view is the best view to evaluate the value of this approach. That will clearly show the coronal view clearly shows the petrosal fissure, I mean the horizontal fissure, from the surface of the cerebellum to the lesion. I think that will be helpful. Anyway, thank you very much.
Professor Mathurya?
Yes, Divya, excellent approach you have described and already told by the Dr. that he has got a good experience on that. Say only one comment. Say since you are a beginner, so it's a one comment to you. And initially, when you started opening the fissure, that time the magnification of the microscope was quite low. When you start opening the fissure, the microscope magnification should be quite high. So you will be able to define the things far better than what you are able to do that. Because many a times what you find with the Carl Zeiss microscope, the magnification we are unable to reach to that magnification which we are able to reach with Mitaka, which is sold in Japan and now it is there in India also. So you should try and use the higher magnification right from start when you are opening the fissure.
Sure,
so
sir.
that
Thank
is
you for your
something.
advice. Well
Okay,
taken.
thank you. So nice. Thank you very much.
Okay, thank you very much. Divya was fantastic. I think what you need to tell, I think when Ben asked the question, or I think O'Hara asked the question, I think what you need to tell them is it's an intraaxial tumor. So I think in their mind they've got it like, they can go from the cerebropontine cistern and go in. It's actually an intraaxial tumor. That's why Divya is approaching that way. I think O'Hara, so then you can understand why she has to go in through her approach. Okay, so I think now we can, Prof. Kato, you want to comment anything?
Thank you very much, Divya.
Thank you, ma'am.
Oh, thanks a lot. So I think May asked about endoscopic approach. So even in endoscope, I think maybe retrosig approach is one of the best routes, I think. We should start.
Sure, ma'am. If the hospital management buys some. Thank you.
Okay. And OSSA is one of the best skull-based neurosurgeon, of course, and the Ōtai Sensei as well. I think you can read with the OSSA and the Ōtai Sensei textbook, please. Thank you.
Thank you, ma'am.
Conversation, excellent talk. Thanks.
Thank you so much, ma'am.
Thank you, Divya. Nice to see you again. So we'll go on to our final speaker. Our final speaker is Dr. Chia Hsien Liew. She's doing a PhD degree under the supervision of Prof. Ying-Mao in the Department of Neurosurgery at Huaxin Hospital, Fudan University in China. So, Chai-Sin, are you ready?
Yeah, I'm ready. Good evening, every professors. Now I'm sharing my slides with you.
Chai-Sin, I think you have to put it on full screen.
And wait a moment, there's something wrong. Good evening, every professors. It's my great honor to have the opportunity to speak at this phenomena. Today, my topic is molecular anatomy in diffuse midline gliomas and epigenetics. We all know DMG is a deadly pediatric and adolescent central nervous system tumor. It's localized along the midline structures of the brain atop the spinal cord. It accounts for 15% of all pediatric high-grade gliomas. It presents the highest mortality rate of any cancer. Its median overall survival is less than 1 year. Palliative radiotherapy is the only standard treatment and is largely used to manage cerebral edema and neurological symptoms. It has no significant improvement of overall survival, and CAR T-cell therapies are an emerging therapeutic option for DMG. In DMG patients, the BBB is usually intact. It can prevent chemotherapy drugs from reaching the tumor site. Because DMG often carries histone mutations, there are not many small molecule inhibitors that target epigenetics in development. The infiltrative nature and sensitive location of the tumor render surgical removal and biopsies difficult. As only post-mortem tissue was available, we have limited knowledge about this cancer. Recent advances in tissue acquisition and molecular profiling revealed that DMG and recent advances in tissue acquisition and molecular profiling reveal that DMG and GBM are distinct disease entities. They have separate tissue characteristics and genetic profiles. Compared with GBM, DMG consists of heterogeneous tumor tissue with a high degree of intratumor homogeneity of driver mutations. In GBM, the microenvironment shows high levels of immunosuppression. They characterized by infiltration of Treg cells, and the ratio of CD8 positive to CD4 positive T cells is increased. Also, the number of NK cells is increased. The TAM population shows more than pro-inflammatory markers and is associated with M0 phenotype. TAM shows an increase in the CD163 to CD68 ratio with increased PD-L1 expression. Many cytokines and chemokines have been found in GBM samples, but in DMG, there is no decrease no increase in T cell infiltration, and the number of NK cells is decreased. Also, the TANs is unpolarized. They show lower inflammatory markers, and there are only some certain chemokines and cytokines are defined in DMG samples. DMG tumor burden continually increases following diagnosis. Similarly, the clonal heterogeneity of DMG evolves throughout a patient's disease, potentially influenced by endogenous and exogenous factors, including microsatellite instability and treatment. As the tumor grows and diversifies, it gains new driver and pathogenic mutations. In addition to the increased clonal heterogeneity and tumor burden, non-genomic factors fluctuate throughout disease progression and likely contribute to growth and survival. The patient's degree of motor function is inversely proportional to tumor burden, whereas the modification is relatively proportional to tumor burden, beginning with a sharp increase at diagnosis, sustained, then decreased during radiotherapy, and adjusted to meet the patient's symptoms. Most frequently, DMG is localized in the pons, midbrain, and thalamus. About 60 DMG patients exhibit histone 3, exon 3, lysine 27 alterations, and 20 DMGs exhibit histone 3, exon 1, lysine 27 alteration. Only a small subset of histone 3 wild-type DMGs overexpress a protein termed 𝑬𝒑𝒂𝒄. Meanwhile, 𝑐𝒂𝒂𝒑 alterations in TP53, ACNS, MYC, EGFRA, and elements of PI3K pathway are common, and they may play a role in the immunosuppressive microenvironment. But in the supratentorial context, it is usually accompanied by mutations glycine 34 to Arginine or lysine in histone 3, exon 3. 𝑑𝒓𝒐𝒄 overexpressing DMG are a recent addition to the new WHO DMG subtype classification system. Its overexpression occurs in most wild-type histone 3 DMG cases, showing the global trimethylhistone 3 lysine 27 hypomethylation in DMGs. It suppresses EZH2 function to facilitate global histone 3 lysine 27 trimethylation. Regarding the age at diagnosis, the median age of histone 3 wild-type patients was almost identical to histone 3, exon 3, lysine 27 alterations, and significantly higher in comparison with histone 3, exon 1 mutated patients. The overall survival of patients with histone 3 wild-type was similar to histone 3, exon 1, lysine 27 altered patients, and significantly higher than exon 3, lysine 27 altered patients. The median overall survival of histone 3, exon 3, lysine 27 altered patients is only 10.8 months. And histone 3, exon 1 is a canonical histone 3 forms and is incorporated into DNA during S phase by chromatin assembly factor 1 and as DNA repair cells in a replication-dependent manner. In contrast, the incorporation of the non-canonical histone 3, exon 3 is independent of replication, and it can occur in non-dividing cells. Histone 3, exon 1 differs from histone 3, exon 3 by 4 amino acid substitutions. These clustered amino acids that differ between exon 1 and exon 3. They have been linked to the differential binding of reactions. In normal cells, TRC2 regulates gene expression by adding the methyl group to the histone 3 protein at specific locations, including histone 3 lysine 27. This modification is associated with a repressed chromatin state. It inhibits the expression of genes in that region of the genome. However, in DMG, the mutations in the histone 3, TRC2 strongly binds to this mutation and cannot properly add the methyl group to the nascent histone 3 protein at histone 3 lysine 27, thereby resulting histone 3 lysine 27 hypomethylation. The affected chromatin regions become constitutively active, leading to the deregulation of gene expression and ultimately promoting the development and progression of tumor. The mutations in histone 3 can not only inhibit PRC2 function, but also overexpress PRC2 subunit BMI1. This enhancing its sensitivity to PRC2 inhibition, block the differentiation of OPC-like cells, and drive the progression of histone 3 altered DMG. OPC-like cells exhibit greater proliferation and tumor propagating potential than their more differentiated cells, and they are at least in part sustained by PDGFRA, suggesting that the OPC-marked PDGFRA could be a lineage-defined therapeutic target. And we can see that through the single-cell RNA sequence of histone 3 altered DMG, we can see that tumor cells differentially expressing the OC-like, OPC-like, and MES-like, AC-like, and active cycling signatures. But most tumors are stored in a cancer stem cell-like, that's OPC-like state. And they are present in all tumors, independent of age or location. This indicates OPC-like cells to be the core of histone 3 altered mediated tumorigenesis. Next, we can see that through the multiplex IF imaging of histone 3 altered DMGs, it indicates a preferred mitotic niche of proliferating OPC-like and OC-like cells, and encircled by more differentiated non-proliferating AC-like cells. It supports a direct cell intrinsic effect of the histone 3 mutation to screw tumor cells toward an OPC-like instead of a neuron-like identity. And histone 3 altered leads to embryonic lethality in top 10 stem cells, but is tolerated in an NPC context. Transcriptome profiling of primary histone 3 altered DMGs indicate these tumors follow a cell hierarchy resembling the development trajectory of NPC to OPCs to oligodendrocytes. Generally, NPCs undergo symmetric cell division to produce an initial pool of cortical progenitors. It later transforms into VRG cells. VRG cells begin asymmetric cell division to generate another VRG cells and a nascent projection neurons. Additionally, some populations of RGC daughter cells become IPC or ORGC in the SVZ. After the neurogenic stages, the radial scaffold detaches from the apical surface, and VRGCs become gliogenic, generating astrocyte or transform into epidermal cells. In normal development, OPC originate in neurocephalea zones surrounding the ventricles. Its specification occurs in waves that are spatially separated in the fetal brain, with the first originating in the SVZ and shifting dorsally with the lateral wall in the second. And the histone 3 lysine 27 altered DMG mediated antigenetic activation prevents normal differentiation of oligodendrocytes. It originates in distinct committed OPC in the midbrain and hindbrain. They show high expression of canonical OPC markers such as oligo2 and PDGFRA. In contrast, the mutation glycine 34 to arginine and valine in histone isoform 3, high-grade gliomas often occurs in supratentorial cortex. It's derived from a forebrain interneuron progenitor in the lateral ganglionic aminas. They express FOXG1 and DRX1. In addition, we can see that neurons produced during neurogenesis can promote the progression of DMG. the neural signature of DMG can predict patient survival. And the results of in vivo experiments often indicate that DMG cells interact with neurons, which is mediated by the chromatin remodeler CHD2. And furthermore, neonatal induction of histone 3, isoform 3, lysine 27 alteration cooperated with activating PDGFR mutant and TRP53 loss to accelerate development of diffuse brainstem gliomas that and it is recapitulated human DMG gene expression signatures. They showed global changes in histone 3 lysine 27 post-translation modifications. In addition, mosaic histone 3 isoform 3 lysine 27 alteration and TRP53 loss drives transformation during neural development in utero. Expression of histone 3 isoform 3 lysine 27 alteration postnatally or in the entire stem cell pool fails to transform. Adding PDGFRA overexpression can accelerate disease onset and increase tumor invasion. At histone 3 mutant 3, histone 3 isoform 3 mutant DMG is often associated with loss of function mutations in its co-rupture ATRX. We can see that the histone 3 isoform 3 lysine 27 alterations and lockdown ATRX and P53 in embryonic MPCs can lead to tumorigenesis in postnatal animal. And these lesions are positive for Ki67, olig2, and nestin, and they were depleted of lysine 27 triple methylation signal. And of course, in histone 3 lysine 27 altered DMG, the tumors occurs in children are larger. They are more aggressive and have a poorer prognosis than those occurring in adults. This is consistent with the previous conclusion. DMGs have been reported to be dependent on neuronal growth factors such as the BNDF and NRGN3. It is secreted by OPCs and neurons, and it can be cleaved by the ADAM10. Antigenetic events such as DNA methylation and histone acetylation are found to be dysregulated in the tumors. And the DNA methylation, and we can use the chromatin modifiers inhibitors such as the BAF inhibitors, EDH2 inhibitors, and HDAC inhibitors have shown promising preclinical benefits. Also, CAR-T therapies also have shown promising results. And GD2 targeted CAR-T cells have been well tolerated in clinical trials, and we can see that GD2 is a glycosympholypid lipid. It is expressed at high levels in histone 3 lysine 27 altered DMGs, but it is far lower in histone 3 wild-type DMGs. GD2 targeted CAR-T therapies demonstrated complete tumor clearance, and it can significantly improve the survival of mice. Also, the small molecule ONC201 shows promising efficacy. It is a dopamine receptor D2 antagonist. Patients treated with ONC201 following initial radiation, but prior to recurrence demonstrated a median overall survival of 21.7 months. But those treated after recurrence had a median overall survival of 9.3 months. Mechanistically, ONC201 can reverse the global histone 3 lysine 27 triple methylation hypomethylation caused by the histone 3 lysine 27 alteration. It can decrease the TCA cycle metabolism, and it can increase glutamine metabolism. It lowers the activity of OGDH, resulting in the accumulation of FKG and L2HG, and a subsequent increase in the the triple methylation in histone 3 lysine 27. This suggests that targeting epigenetic changes caused by histone alterations is an effective strategy for the potential precision treatment of histone 3 lysine 27 altered DMGs. Thank you, my advisor, Professor Moy and Professor Xu Bing. Thank you, everyone.
Thank you so much, ASEAN. Are there any questions from the floor? Prof. Otani? Prof. Oya? Itichai, are you around?
Yes. Thank you, Dr. Lin, for your good presentation. And so it's very so difficult to treat and manage the diffuse malignant midline glioma. So I usually just perform the open biopsy to get the definite histological diagnosis. So after that, this adjuvant therapy, such as Temodar, oral administration of the Temodar and the radiosurgery, will be needed for the malignant tumors. So in your presentation, the H3K727 histone altered glioma, how do you think about the changes of the characteristics of the these gliomas? So how do you think about the changes of the characteristics of the H3 altered and glioma? Do you think about?
The histone 3 lysine 27 alteration can change the chromatin state. It can inhibit the methylation of the histone 3 and can let the chromatin in an active state, and some oncogenic gene can express and transform the normal cell into a tumor cell.
Okay, so what in this I think so one question there. How do you think the development of the treatment? So for your molecular research, you understand? So it's histone 3 altered and K72 altered. So you what do you development for the treatment? So such as the inhibitor or the gene therapy or the what?
Yeah, well, our team have developed a spontaneous tumor model for the histone 3 lysine 27 alterations, and now we have such some inhibitors that can extend the survival of mice.
Okay, yeah. Thank you so much for your very good presentation. Thank you so much.
Yes, a question, Hui Pam, you can continue.
Yeah, thank you for the nice presentation with very detailed information regarding the molecular profile of brain tumor. I have one question that as we know that now they have the theory of tumor stem cell, especially for malignant brain tumor, and it might develop into different types of cells within a single tumors. So do you find the difference in terms of molecular profile within a single tumor for diffuse midline glioma?
The single cell, our single cell data shows that the DMG tumors have distinct characteristics from the GBM, and some papers also show that the DMGs can develop from the neural stem cells, but in our model we can't develop the tumor model from the neural stem cells, but we can. And in our spontaneous tumor model, we stain the markers for the tumor, and we found that the tumor is originate from the OPC-like cells.
Yeah, and it's true for midline gliomas as well. Okay, thank you very much for the answer. Yeah.
Prof. Oya, do you have any comments?
Okay, well, I'm just a humble skull-based surgeon with a very simple circuit of brain, so I don't think I'm proper person to make a comment, but I was actually impressed by knowing that your research is actually being in the development phase of the new treatment. So we're comparing the GBM, because the GBMs are for GBMs there are many clinical trials, and actually some molecular the agents are being used, but for midline gliomas, what's the biggest obstacle for you to bring your research into clinical trials or clinical application?
Maybe it depends on the deliver efficiency, because the infiltrative nature and the special location. Maybe we cannot deliver the drugs through some simple ways. We can combine the technologies. For example, the gels. We can mix the drugs with the gels, and it can improve the delivery efficiency to cure the tumor.
I see. That's very reasonable. Thank you.
Thank you, welcome.
Prof. Kato, do you have any comments, Prof?
So yeah, ACNS.
Yeah.
Yes. Okay. Thank you, Professor, and thank you, Dr. Liu, to present a very amazing for your research about the molecular study in the midline glioma. Regarding to the diffuse midline glioma, is really poor prognosis now, because we cannot win about this pathology, and we cannot kill disease by surgical resection, because difficult anatomical location of this tumor. And how about your opinion? Now we can change the standard treatment from the radiation or the chemotherapy to another innovation treatment because disease is really short time for survival. So if we have like a near future technology or innovative treatment, maybe we can win above this pathology. How about your opinion, Dr. Liu?
Because when the DMG is diagnosed, the patients will die in a short time. So sometimes we maybe cannot and sometimes it's not easy to the drugs to kill the tumor, and we can for the chemotherapy. And now we know that the chemotherapy is not applied to the DMG patients because it have big side effects, and maybe the radiotherapy can combine the precision therapy, and the precision therapy requires we to find the precise target. And when we and now I'm trying to screen the small molecule inhibitor, and we and it cannot have a broad effect. It aims to target some gene or some proteins. When combined, and we can combine the technology, for example, the nanoparticles to enable the drugs to improve the efficacy of the delivery efficiency. And when combined with other, for example, the CAR-T cell therapies, it may improve the therapeutic effects in the DMG patients.
Appreciate your answer. Thank you, Dr. Liu. Thank you.
Thank you.
So Sharon, unmute, please.
I think there's one more question from Mikal. Mikal, again, you want to ask your question? Oh, and also Prof. Yeah.
Thank you. It was a nice, excellent presentation, a bit detailed. So I just want to ask you, is the genetic mutation different with the midline gliomas? And rarely there are diffuse gliomas which are hemispheric. So is there any difference on the molecular pattern? Those present on the hemisphere and the midline.
The difference?
Yeah, molecular, the genetic pattern, like the H.
First, as I showed the slides, in the cortex, there are always accompanied by the mutations in histone 3, exon 3, the glycine 34 to the and H9, and it accompanied by a series of somatic mutations such as the TRP53. And in the midline, there was no mutations. We cannot find the mutations with the histone 3, exon 3, glycine 34 to the H9, and they always had the histone 3, exon 3, lysine 27 mutations. And the different mutations have different effects. For example, the glycine 34 to the H9, it can affect the immunosuppressive microenvironment. For example, when we targeted the histone 3, exon 3, glycine 234 H9s, we can see that the DNA damage is it can promote the DNA damage, and it can activate the signaling pathway. It can enhance the immunotherapy when combined other, for example, the CAR-T therapies and other checkpoint inhibitors. But yeah, in histone 3, exon 3, but in histone 3, lysine 27 alterations, we have not seen the inhibitors targeted to the for example, just the EZH2 inhibitors cannot exert the immune efficacy.
Thank you. Thank you very much.
Thank you. Thank you.
Mary Prison?
Prof. Prasad, you want to ask a question just now? You want to make a comment?
Hello, just a comment. Hello, salam alaikum, konnichiwa. And just like to say salam and Eid Mubarak for our Muslim ceremony. Eid Mubarak. And I would like to say congratulations and thank you for your achievement and presentation for 3 of our ACNS WIN members. We are proud of you. It was excellent presentation and excellent achievement. Congratulations to Professor Yaku Kato and Abidasha and all of our WINS committee colleagues. Thank you very much.
Thank you. Thank you.
I think we're coming to the end. So, Kato, you want to make some closing comments?
It's fine. Dr. Liu, thank you very much once again. So I think in China, maybe you may have many cases, I think. So please keep going your advanced research work, and please welcome back the accumulated the new result, I think. Thank you so much. Congratulations.
Thank you.
So thank you, everyone. Thank you, Prof. Otani, for chairing today's session. Thank you, Prof. Itichai and Prof. Oya for being our discussants. Thank you, everyone, for joining us. And thank you most of all to Prof. Kato for giving us, the Women Neurosurgeries, this platform to present. Thank you all, and have a good week, and see you all again next month. All right, bye.
Thank you. Thank you.
Bye. 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 John, thank you.